Welcome to our Healthy Lifestyle Talk. This evening we'll have a guest speaker to talk on preventive cardiology. I'm Dr. Kamei, the Medical Director of the Cardiopulmonary Department at Northern Inyo Hospital. Heart disease is the #1 cause of mortality in the United States. In 2018, approximately 2,400 people died each day from heart-related causes. In 2013, a study on women showed that approximately 290,000 women died that year from heart disease, compared to 39,000 from breast cancer. Because of the magnitude of cardiovascular diseases, we felt this talk was crucial to be given to our community. I'd like to take you all on a tour of our cardiac department and show you the procedures that we can do to help manage and monitor our patients with cardiac diseases. In our department, we have 2 certified EKG technicians, Michaela and Carrie. We also have outstanding echocardiographer, Terry, who is literally nationally renowned and is certified. David, who's not in our video, is our most recent certified echocardiographer. In addition, we have Mike, who's our nuclear cardiac scanner, and he's licensed in nuclear medicine. Our manager for the cardiopulmonary department is Amy. So with all our personnel here, we're able to provide excellent diagnostic treatments. The cornerstone of the EKG department is our EKG machines. We just updated our equipment last year to include the new system that ties directly into our computer system, so that even though we can give a paper copy, all the tracings are sent electronically to our computer, and the physicians will interpret the EKGs online, and when they're signed off, they're immediately available to all the personnel that needs to have access to this information. So one of the common complaints patients will have is they complain of palpitations, and we have devices that can help the doctors diagnose what type of palpitation the patient has. We have several modalities here. I think we'll talk about the Zio patch first. You can show them that patch. This is a very useful tool. As you can see, it's a very small unit that the patient will wear for anywhere from 7 to 14 days. After that time, they mail it into the company, and the company will analyze the rhythm and then download the results, which we can obtain online to determine if the patient had any significant arrhythmias over that time frame. Now, sometimes the patients don't have a lot of arrhythmias, and they may have it just once a month or so. So there is another modality called the event recorder, where the patient can be set up on this type of monitor for up to 30 days. And then that goes to the company, and they can analyze any abnormal arrhythmias. Now, we have quite a few people here who have pacemakers, and there's different types of pacemakers, and we have 3 units here that can analyze the pacemaker data and send it back to the cardiologist. So Carrie can explain what we have.
We have 3 devices. One is, this is the Boston Scientific, and then we also have Medtronic, and we also have St. Jude. These are the 3 pacer checks that we have that we're able to do that for our community.
So this data is downloaded to the appropriate company, and they will do the analysis and send the reports to us, often to the emergency room, especially if the patient is in the emergency room for some problem that may indicate a pacemaker malfunction. We also do stress testing. We actually have 3 different modalities of exercise stress test. The first one is a very good screening exercise stress test, as long as the patients are able to exercise to within 90% of the predicted maximal heart rate. Occasionally, we want to have an increased sensitivity for diagnostic purposes, with a stress test. So we have the capabilities of doing an exercise echocardiographic stress test as well as the exercise nuclear stress test. The way we do this is similar with the exercise component. However, at the end, for an echo stress test, we immediately lie the patient down so that Terry can do a post-exercise echocardiogram, which can detect wall motion abnormalities that may indicate significant coronary artery disease. The other method that we use is an exercise nuclear scan, in which we exercise the patient to within 90% of the predicted maximum heart rate, inject an isotope that tags the heart at peak exercise, continue exercising for a minute, and then after recovery, take the patient over to the nuclear camera to take pictures. We can look at the pictures after the infusion and compare them to a resting picture to see if there's any difference. Because if part of that heart is not receiving adequate blood supply, that muscle or wall does not contract normally, and we can identify that on the pictures. We have, as I mentioned, a fantastic echocardiographer, and I'm going to turn this over to Terry to show you what the echo component of the department entails.
So an echocardiogram consists of a very detailed look at the heart, all the different components of the heart. It typically takes 15 or 20 minutes to do, and we require 50 or 60 of these 3-beat video loops. So this is just an example of what images from a stress echocardiogram show. The images on the left are at rest, and you can see the heart rate here is 77, and then the same image post-exercise where you see the heart rate is 154. And we take these 4 different images here so we're able to visualize all the different portions of the left ventricle, which is the part of the heart that is most commonly affected by heart attacks. You can see how hard the heart's working here after the treadmill exam. This is an example of an individual suffering from severe heart failure. And if you focus on this chamber, the left ventricle, compared to the previous image you looked at, you can see that the heart is contracting very poorly. So this is a pediatric patient. This particular patient is 6 years old. You notice the heart rate's quite a bit faster than the previous patients, and that's typical for children. Their heart rates typically run, depending on the age, anywhere from 100 up to 150 or 60 when they're really little. It's the right side of the heart filling with saline solution that causes a contrast effect. And in the left side of the heart, you'll see a bunch of little white dots floating around, and that tells us that this patient has an opening between the left and the right atrium that could be a possible source for the cause of their stroke.
Now, people are always worried about, quote, getting in shape for the stress test, or gee, they can't do very well, or what if you find something? From our point of view, if we do find something in a patient who is active and we refer them to the centers and they indeed undergo one of the newer procedures to open up the arteries, we've literally been able to save the patient's lives or at least improve the quality of their lives. So that's one of the big things that we've done here, and we are so grateful to the cardiology group in Renown who've accepted so many of our patients and have done all their invasive testing and procedures and have truly improved their lives. Tonight's guest speaker is Dr. Chris Rowan, a cardiologist from Renown Institute for Heart and Vascular Health. Dr. Rowan has been working in Renown since 2015. On a personal note, I'm really grateful that he's coming here to speak to us. The group has evolved, and I've worked with them for over 40 years. They've been a godsend to our cardiac patients in Bishop. They have been so incredibly kind and generous of their time. We're able to get a hold of them when we need to. They've come to our aid multiple times, and we have a great collaboration with the group. So Chris is standing on the shoulders of some fantastic cardiologists. And again, I appreciate that they've carried on the tradition of excellent cardiac care. So with no further ado, I'd like to have Dr. Rowan give his lecture on preventive cardiology. And any questions are welcomed at the end of his talk.
Well, thanks everybody, and thanks for having me tonight. One of my favorite areas to go in the world is the Bishop Mammoth area, and I've been going down there for years. And one of the reasons I took the job at Renown was because it gets me back into the local area. So again, thanks for having me tonight. Let me get my screen going here. If you give me 1 second. Okay. There we go. Oh, sorry, got the wrong wrong screen there. There we go. All right. So I'm normally from Reno and from Renown Heart and Vascular Institute. I'm also the director of heart failure in Reno right now. We receive a number of patients from the local area. And let's talk about heart failure, heart disease, coronary disease. So right now, heart disease in the world is the leading cause of leading cause of death in the world entirely. It's the leading cause of death for men and women in the United States. 1 in 3 people worldwide will die of heart disease. So 31% of all the world's population is going to die of that. In England, it's higher at 34%. In the European Union, European countries, about 40%. Last year in the United States, about 360,000 people died. Every 36 seconds in the US, someone dies of heart disease. And it led to a cost to our medical system about $363 billion in 2016. And that's obviously much higher these days with inflation. So it's a huge burden both to our medical system and to our patient population. Here in the United States, about once every 40 seconds, somebody has a heart attack. And I didn't include this, but if a person has a heart attack, unfortunately, 50% of those patients I'm never going to meet because they die before they ever get to the emergency room. So probably once every 80 seconds, somebody dies of a sudden cardiac death in the US. That's 805,000 total people per year. And out of those, 1 in 5 people has what's called a silent heart attack, which is a heart attack during which time you're never going to have any symptoms, which is a little bit strange, but we do see it. And it leads to heart failure and other issues that I end up then having to try and take care of. But prevention. So let's talk about how to prevent you from developing heart problems. The first thing is, are there natural cures or natural things we can do to prevent people from having heart disease? Well, unfortunately, there's no magic bullet here. I have nothing I can pull out and say, take this herb or take this vitamin and you'll be fine. When we look at things that may have had promise during other times, such as garlic, pomegranate juice, omega-3, before I gave this talk, I Googled the term how to prevent heart disease naturally, and I came up with all these different holistic cures. And, here's the thing to remember is that when these things have been really, really tested in a robust clinical trial, they failed to really show a benefit. And as I tell a lot of my patients, if we believe in the idea that drug companies are greedy and all they want to do is charge us a lot of money, which, I have no reason to doubt that, what I would tell you is, if these natural substances performed like we think that they would, well, then they can just simply look into what is in that natural substance, identify it, patent it, and make it into $1 billion drug. And yet this stuff just doesn't seem to happen. So that extension of the idea of natural substances working and then turning into a drug therapy seems to fail in that next step. And that's a really important thing to remember. So here's an example of some stuff. Arsenic, uranium, a tornado, and obviously a great white shark. And what are all these things have in common? They have in common that they're natural. They're natural substances. And just because it's natural doesn't mean it's good for you. Sharks are bad for you. Tornadoes are bad for you. We don't get them out here, but back in the Midwest, and when I used to live in Philadelphia, we had tornado warnings, which were fairly scary. And obviously, arsenic can poison you and kill you, and uranium, we all know what that does. So they're all natural. It's not necessarily good for you. And if there was a magic bullet out there, we certainly would endorse them as doctors to you and tell you, hey, go take this or do this. But the science just fails to really show you anything there. So let's look at the natural history of heart disease for a very brief minute. Is heart disease a natural or is it a phenomenon of modern living? Well, I'm part of a team that, I don't want to go too much into this, but we study mummies from around the world, including South America, Egypt, Greenland, and mummies going back as far as 4,000 and 5,000 years. And we've seen heart disease and the process of atherosclerosis in every population we've studied. So it is unfortunately there. It's just becoming more prevalent in our modern society for reasons that we'll get into. But who has the healthiest hearts in the world? And it's these people right here called the Chimane Indians. And they're native people who live in Bolivian Amazon that we study. And here's a perfect example of what they eat. They're not eating anything crazy. They're eating beans, they're eating rice. The thing on the left there is a deep fried plantain with a little bit of meat. So they eat the same balanced diet that we do in terms of the same protein, carbohydrates, and fats in terms of percentage that we do. But what makes them different? What have we learned? Well, we learned there's no trans fats in their diets. They have a very low sugar diet, or low in refined sugar. They do about 17,000 steps per day up until about the age of 65. And they have had the least amount of heart disease of any population studied so far in the world. And that includes populations like Japanese, the Okinawan people, some of the tribes in Africa, less than all those people. So you don't have to be skinny and tiny and thin to have low heart disease. You can see these people, although they're not obese, they're not exactly, 6'2" and 100 pounds. What's different is they're very physically active. And although they eat a balanced diet of fats, carbohydrates, and sugars, they're natural sugars, and they don't use a lot of, obviously don't have access to a lot of things in their pre-modern diet. In terms of physical fitness, one of the things to remember is I ask my patients all the time, how active are you? How physically fit are you? And I'm not really saying, do you go to the gym and run on a treadmill and do you lift weights? What I'm saying is, do you do something outside? Looking again at these ancient populations and these pre-modern populations, how did they live? And the answer is they're just always up and doing stuff. They get up when the sun comes up, they're walking around, they're doing things. They're not running, they're not lifting weights, they're not at the gym, but they're certainly very, very active. They don't follow a keto diet. That's sort of a made up thing in Western society, which has really never been shown to help. And in fact, is shown to increase cholesterol and worsen your cholesterol and make you higher risk for heart disease, but they're constantly active. And the degree of inactivity in our societies nowadays is unprecedented in our human history. There's no native population on the world that is as sedentary as we are, and that leads to the higher rates of obesity, heart disease, high blood pressure, diabetes, and stroke. And as an extreme example of that, what's interesting from a scientific standpoint is patients that are paraplegic or quadriplegic, even though they may not be overweight, they are extraordinarily high risk for heart disease by nature of their inactivity. And a lot of those people that I take care of have multi-vessel disease, have had to bypass numerous stents by the age of 40. And by the age of 60 or 70, they're even worse off. So that's what sedentariness does to your system. Another risk factor is smoking. At this point, if people are still smoking and wondering about your heart health, there's certainly absolutely no question that it's bad for you. But how? How does that happen? So, just because you smoke a cigarette, does it then lead to heart disease? Well, what happens is you have a number of immune cells in your lungs, and those cells pick up the foreign objects, the smoke particles, and all those toxic things, and they send out a distress signal to the rest of the body. Those distress signals then go to the liver, the kidneys, the heart, and activate certain pathways that then lead to the upregulation of clotting factors, cholesterol. They make the cholesterol more sticky, more likely to adhere to the arterial wall. They signal the immune system to become more active, to create more problems, and it starts to create plaques on the arteries. So even though, in a very simplistic way, we just think of smoke going to the lungs, it creates this incredibly inflammatory reaction throughout the entire body. No level of smoking has ever been shown to be safe. So even if you're smoking a couple of cigarettes per day, thinking that's better than a pack per day, that's partially true, but the risk begins at 1 cigarette per day and doesn't end after that. In fact, right now, the US national screening guidelines are, if you have ever smoked a cigarette ever in your life, you're at risk for a ruptured abdominal aortic aneurysm, and you need to be screened for that. So 30% of the current total US risk for cardiovascular disease is estimated to be from smoking. It doubles your 10-year risk of heart attacks. It's the single most effective thing you can do to lower your risk of heart disease. And think about that. You go to your doctor, am I going to put you on a drug? Am I do this test? Or I'm going to do all these very, very high-tech things? Well, the one thing you can do, or you can encourage people to do, is quit smoking. The average number of time it takes for people to quit smoking is between 7 and 9 times. So what does that mean? There's all those patients out there that say, I quit cold turkey. They are the absolute outliers. And tell your friends and family and maybe yourself, that's not what I should expect. It takes a lot of times to quit smoking. E-cigarettes, there's no long-term data on this, but the early information suggests it's just every bit as bad as normal smoking. And hookah, which is a newer thing that's becoming more popular amongst the younger, hipper crowd, is every bit as bad for you. And there's a lot of studies that show that's just as worse. There's no reason to be smoking. Smokeless tobacco, chewing tobacco, those sort of things, it's every bit as bad as nicotine. And it's the nicotine component that also creates the problems. Diet, here's one of the things I tell a lot of people, and forgive me for saying this, I don't have any patients that are vegetarians. And it's not because they all die before they get to me. It's because vegetarian diets they don't create heart disease, or it's very, very rare that they do. Now, does that mean I want all of my patients to become vegetarians? No. You certainly should try to become more conscious of what your diet is and change it so that you're eating less red meat and less fried food. I don't expect everybody to drop all of their habits, because even I'm guilty from time to time of indulging stuff. But the point is, life is a spectrum. And the more you go towards those vegetarian and low-fat diets, the better off you're going to be. Though it's hard to change, moving that direction is definitely better for you. Now, nowadays, if you start trying to cook vegetarian with some of the newer meat substitutes that are available, it's actually pretty good. I remember my sister, when she tried to make a vegetarian hamburger when I was back in high school, it looked like dog food. It was absolutely awful. And nowadays, it's actually really quite good. The keto diet, again, it's actually associated with higher cholesterols and heart disease. We actually had an anecdote about 2-3 years ago where a patient changed to a keto diet, and their cholesterol tripled and they had a heart attack 3 weeks later. Now, they probably lost 10 pounds getting to their heart attack, but I don't think that's really where they wanted to be. Intermittent fasting, that's a newer trend. There's absolutely no proven benefit in that whatsoever. The one diet, actually 2 diets that have been shown to be very, very beneficial for you is what's called the DASH diet, which is low in sugar and saturated fat, emphasizes vegetables, what they call legumes, which are less starchy vegetables, and emphasizes less meat or leaner meat, such as fish. And then the Mediterranean diet, which is also the same thing, which emphasizes omega-3 rich olive oil, fruits, vegetables, etc. The thing I would tell you is, nowadays with Amazon and all those other online deliveries, it's very, very simple to get a good diet book and find some of these diets, because no diet's going to be sustainable if it tastes terrible. But a lot of things like the Mediterranean diets are actually very, very tasty and very good. And one of the things that me and my wife have done is we've joined one of those delivery meal clubs that's vegetarian, and they deliver a lot of recipes. And I have to tell you, a lot of them are absolutely amazing. And they're also teaching us to cook along the way. So, as part of that process, we're eating better, we're eating less, we're eating healthier, and we're also eating food that's really, really good. And that's important. You got to enjoy your meal time. So this is from the American Heart Association prevention guidelines, looking at different diets. And here's what they're emphasizing. And forgive the things like COR and LOE here in the blue and the green. The COR means basically what is the level of recommendation, and LOE is level of evidence. If it's class 1, it means multiple very large studies have proven this to be true, which means that a diet emphasizing intakes of vegetables, fruits, legumes, nuts, whole grains, and fish lowers your risk very, very significantly at ASCVD. That's atherosclerotic cardiovascular disease, meaning stroke, heart attacks, vascular disease. Getting rid of saturated fat and looking at mono unsaturated and polyunsaturated fats is very, very beneficial. A diet lower in cholesterol and sodium is very beneficial. So read your labels. And it's reasonable to reduce your intake of meats, carbohydrates, and sweetened beverages. And there's been a lot of papers published in the last 10 years looking at things like diet soda and how it raises your risk of heart disease. So as one way to think about that, just because you eat or drink a sugar substitute, it's still activating the same receptors as the sweet receptors do in your stomach and in your gut, and therefore it's creating a very similar biologic process, though through a very unnatural phenomenon. And then, trans fats, I can't tell you how bad they are for you. They're absolutely terrible. Just don't be on trans fats. They banned them around the U.S. and parts of New York, and it was very, very controversial. But the reason is because it's just so pro heart attack that you don't want to be on them. Physical activity, what they recommend in England is 150 minutes per week or 75 minutes per week of vigorous activity. Any form of exercise lowers your risk. It doesn't have to be a gym. You don't have to run. You don't have to do anything like that. Things like going for a walk. And one of the nice things is you guys live in one of the most beautiful places in the world you can live in. I would love to live down in that area. Unfortunately, my current work keeps me in Reno, but I love going down to Bishop. I love going to the Mammoth. I love spending my time up in the mountains there. Anything up, hiking, walking, hunting, fishing, skiing, any outdoor activity that you can do, 150 minutes a week. That's really not that much. And that's going to lower your risk of heart attacks and strokes. And interestingly enough, if anybody out here has atrial fibrillation, that has been shown to reduce the risk of recurrent atrial fibrillation as well. So physical activity is just so important. What about cholesterol? Know your numbers. Know what your cholesterol numbers are. Your LDL, which is the most important one, the low density lipoprotein. Reducing your LDL by just a measly 40 points lowers your risk of recurrent and first heart attack risk by anywhere from 20 to 25%. Sometimes people quote the ratio. The ratio doesn't really work for individuals, although on a population level, it does predict something. But more importantly, is lower your LDL as much as you can. If calcium scoring is available or you're up in the area where that's offered, such as up in Carson or Reno, getting a calcium score can really, really change your risk, because a calcium score tells you a lot more about your long-term risk of heart disease. It helps us refine our thinking. I've had a number of patients who really don't have a lot of high cholesterol markers, but by the time they get their calcium score, we find out, lo and behold, they're actually the highest risk patients overall. Other risk factors, so if you have a family history of heart disease, and that is men under 55 and women under 65, that's an independent risk factor, so let your doctor know about that. If your LDL cholesterol is over 160, that's another risk factor for heart disease. If you have kidney disease, that's another risk factor. If you have chronic inflammatory conditions such as rheumatoid arthritis, lupus, psoriasis, that is a risk factor. If you have a history of premature menopause, and usually seen such as in women, like women who've had a hysterectomy with their ovaries removed, that becomes a risk factor for early heart disease, because for some reason estrogen seems to prevent heart disease by about 10 years. And other women who've also had a pregnancy complication such as high blood pressure or what's called preeclampsia, that does put people at higher risk. Metabolic syndrome, which is a big waist, high triglycerides, elevated blood pressure and glucose, that's also an independent risk factor. So get those under control. Get your cholesterol under control. Get your blood pressure under 130 over 90. There's I think it used to be, we thought the bottom number, in this case, the 90 was the more important number. It's actually the top number, which is the most important number. That should be under 130 according to the most recent sprint trial. And then the bottom number is important, but not as important as the top number. Get your diabetes under control. Work with your primary care provider to get it, your A1C back under goal. And as a little bit of as an aside, the newer drugs, which are called GLP-1 inhibitors, marketed as Trulicity and Ozempic, are an amazing class of drugs, but because my patients lose weight, they lose a ton of weight. I've got patients who've lost 150 pounds because those drugs just shut off your appetite and shut off everything. And they are just great classes of drug. I'm very, very impressed with what they do. They can be expensive, but they are really, really helping people, and I'm just saying that I don't get any money from the drug companies. So don't think that I'm, taking kickbacks to make you get on Trulicity or Ozempic. But yeah, they are just amazing drugs. Take your medications. Let your doctor know about your side effects. A lot of my patients say, I don't want to be on these drugs because they get that 5-page list of side effects from the pharmacy and they say, this is what this drug is going to do to me. No, That's what 1% of people in clinical trials experience, but we want you to know about everything that could potentially happen so that you're informed, but that never ever means that you're going to get it. That never means you should ever live with it. I tell my patients first thing when I put them on a drug, most commonly a statin, because they're scared of side effects. I say, if you get a side effect, call me right away. You stop the drug. Don't wait for me to call you. You are never ever supposed to live a life where you feel worse than the drug, than you feel worse than you do today because the drug makes you feel that way. Don't ever ever live like that. But you got to work with your doctor to let them know. If you're a patient of mine by any chance, just call me, send me a message. We'll switch drugs. We'll do something different, because any therapy plan or any drug plan has to meet your lifestyle. And like I said, talk to your doctor. One of the things that a lot of people don't realize, Bishop, like I said earlier, is such a beautiful place to live. It's such a desired place to live for a lot of people. You actually, that draws a lot of people to your area, including a lot of your doctors, your hospitalists, your primary care docs. You guys have, and you're lucky, you have some very, very fine doctors down there. Dr. Engblade, Dr. Kamei, all those people down there are very, very good doctors. Terry Tai, who's the echo sonographer down there, is an amazing sonographer who used to be at Stanford. So you have a very rich talent pool of people down there that you can draw from, and you're more fortunate than a lot of people who live in very, very remote parts of America who don't have that benefit. So work with them to get your numbers under control and learn them. You can always request a consult to come up and see one of us in Reno if you want to make the 3 to 4 hour drive, and we'd be happy to see you up there. So I want to thank you guys for having me tonight. I flew down to California today, so I'm down in California on vacation, but I took time out of this tonight to be with you guys because I think, Bishop, again, is one of my favorite places to visit. And I'm very passionate about the people down there and the life. And I want you guys to be able to stay down there independently as long as you possibly can. So with that, if you have any questions, I'm happy to entertain them.
This is Joy Engblade. Chris, I just want to thank you for that talk. Super interesting. I'm sure you're going to get some questions here pretty soon, but we really appreciate you taking time out of your vacation. As Dr. Kamei said on the video, we really appreciate working with you and your group, always helping with us and all of our patients down here in Bishop.
Well, thanks, Joy. And, like I said, one of my favorite things used to be coming down there to see you guys. Unfortunately, that's not something we do anymore. But, again, you guys are an amazing group of people down there. And we love taking your patients, and we love collaborating with you guys because, as I said, you guys are really talented down there with what you can do. And we like being partners with you guys and taking care of that patient population.
I have a question. Can you hear me? Hello?
Hi, we can hear you, Mary Ann. Go ahead and ask the question.
Yeah, sorry, go ahead. I had a mental brain freeze there where I couldn't figure out how to use my Zoom, but yeah, go ahead.
How long can someone live with congestive heart failure?
Great question. Since I'm I'm the director of heart failure at Renown. Heart failure should be thought of nowadays as something that you live with but not die from. So we treat it nowadays like high blood pressure, high cholesterol. So for a lot of people with heart failure, there's a commercial on TV that says, if you're diagnosed with heart failure, the average survival is 5 years. I've been at Renown for 6 years. I've got a whole panel of patients that are doing much better. Heart failure doesn't mean, pull out your will and say goodbye to your family. It just means, okay, we're just going to put you on a lot of different medications and keep working with you. And as I joke with a lot of patients, and one of who's on the Zoom call, I said, hey, guess what? You and I are going to get to be really good friends because you're going to see me a lot. But they do, with heart failure, with the newer medications that are out in the last 10 years, people do very, very well and should expect to live a fairly normal lifespan.
Okay, thank you.
And just an aside there, one of my patients, Charles, is on the Zoom call there. So just say thanks for joining us tonight, Charles, and look forward to seeing you next time. And he's one of our patients who's been doing very well. and in collaboration with our people down there in Bishop, he gets a lot of his studies done down there. There are a lot of people who go to other hospital systems where I tell them flat out, I don't want you to get a study done at that city. I tell you, I trust everything that's done down there in Bishop, and I fully welcome any echoes, EKGs, stress imaging that's done down there at your hospital, because the people down there are just great, and you should trust them as well. Any other questions, or as I say to my other patients, comments, jokes, political statements, anything?
It does not look like we have any more. Anyone has any, just go ahead and ask them now. Otherwise, Dr. Rowan, thank you very much for your time tonight. We really appreciate having you on, and it was great hearing you talk. Oh, I think we have a question over off of our YouTube channel, actually just coming in now. I'll go ahead and read that for you.
Sure, thank you.
I'm taking anastrozole for breast cancer. I hope I said anastrozole right. It has raised my LDL above normal. Do you recommend a statin, or can it be controlled with diet and lifestyle?
Great question. It depends on how much it's raised it by. Those drugs that for breast cancer that usually have to be on for a very extended period of time, like 5 years, do raise your cholesterol some degree. Do I recommend going right to a drug? Not necessarily. If you can get your cholesterol back under control with, some dietary and lifestyle changes, I certainly would support that as the first line. And that's the first line recommendation as well from the American Heart Association, as well as the American College of Cardiology. Our first line recommendation is never, ever to go straight to a drug. It's to do the things that we think you should do without drug therapy. That being said, if you can't get there with drug therapy alone, with lifestyle changes alone, don't blame yourself. There's a certain degree of your cardiac risk that is genetically driven by how your body metabolizes cholesterol. And so if you can't get there from changing your diet and becoming more active, don't blame yourself. It's not going to be your fault. And I have a couple of patients of mine who are very, very type A executives, and they've changed their diets in ways that you and I probably could never imagine. And they're very, very, very proud because they changed their numbers. They come back and they say, look at what I did. And they're saying, great. And all of them have come back 6 to 12 months later saying, I can't do it. I can't keep this lifestyle up. I've eliminated everything from my diet you could ever imagine. They literally are subsiding off of fruit and water and coffee, and that's it. If you can sustain that for the rest of your life, good for you. But because that problem wasn't caused by you, it was caused by who your parents were, i.e. your genetics. Because you didn't cause the problem, don't flog yourself and torture yourself with these changes that are not going to solve it because you didn't create it. So, drug therapy is oftentimes what we go to. But I would work with your primary care physician to help you identify diets you can change and things you can do to help you lower your heart risk. If you look up the American Heart Association online, there's recommended diets, there's recommended recipes. You can buy cookbooks from the American Heart Association. And like I said, a lot of the food is actually very, very tasty and good and satisfying, which is the number one requirement for any diet.
All right, looks like we have some anonymous questions coming in. So the first one, I'll go ahead and read this one to you. Is there any danger of over-exercise? I've heard of marathon runners with large hearts. Is there any risk of heart-related disease?
We haven't found any so far, although there is a U-shaped curve to exercise, which, a lot of people think, well, if I run 5 miles, that's good for me. Well, the 10 must be better. And then if 10's good, 20 must be better. And if that's good, then, et cetera, until the point that they're running 100 miles. There is a degree to which there's a lack of benefit. So extreme exercise is no better for you, but exercise certainly by itself is. There are, and this is kind of the funny thing when I get into my genetics work, There are a lot of people who have genetic cholesterol problems. So you may have heard of people that are ultramarathoners that drop dead in the middle of a race. Oftentimes what we find is that they had an underlying genetic missed condition that led to heart disease that they didn't know about until, again, they were one of the 50% of people who died from their first heart attack. And that's got nothing to do with their exercise. But by itself, extreme exercise is not harmful, but it's certainly not super beneficial.
All right, I said thank you for that. The next one, we got another anonymous question here. What are your thoughts on the use and success with artificial intelligence with coronary CT angiography, for detecting early stage heart disease?
Oh, great question. I've actually been published and done a few studies on that myself. There's a lot of early work right now in what's called a coronary CT angiography. So what that does, it takes a CT scan of your heart and we create a virtual map of your coronary arteries to identify areas of the arteries that become vulnerable down the road to a heart attack and may need a preemptive stenting. That stuff is, been out there for about 5 years now. It's still early. We're still working on all the information to suggest or to predict what it means, because even though we see something on a CT scan, we may look at it and say that looks like the vulnerable plaque that caused a heart attack on this guy over here a year ago. But how many of those plaques will never do that? That's what we're still trying to work out. But the artificial intelligence work behind it and the machine learning right now being done by groups like HeartFlow and some of those other companies is absolutely amazing right now. In fact, it's been advancing so much that one of the first line tests now recommended for low risk chest pain is not a stress test, but it's a coronary CT scan. And that's what I've been doing down in Bolivia for the last 5-10 years on and off, is doing coronary CT scans. They are absolutely give you so much anatomical information that you never get until you take somebody to an invasive study. I would highly recommend that somebody with chest pain get one. Now, again, somebody with chest pain, if no chest pain, no symptoms, don't do it. But that information right now is developing, and it's to the point where I think in the next 5 or 10 years, we'll be seeing some more advances in the artificial intelligence there. Taking vitamin, there's a question there from Charles. Just heard taking vitamin D3 supplements should be avoided. I think that's somewhat controversial right now. Vitamin D and vitamin D research has been a huge controversial area where they're trying to tie vitamin D into every, trying to make it responsible and causal for everything under the sun. And maybe you're tall, you've got low vitamin D. You're short, you have low vitamin T. You got COVID, you had low vitamin D. Most of those studies are what's called a correlation, meaning the two are related in time and space, but there's no cause identified. So in other words, we can't figure out why vitamin D would cause it. Well, to go to the COVID data, some of the stuff that's been out in the last 6 years last 6 months, looking at COVID is correlating vitamin D levels to mortality in COVID. Low vitamin D is seen more as people get older and infirm, and it becomes a marker of inactivity and lack of being outside in the sunshine. That itself is the cause, but the vitamin D itself is not, if that makes sense.
That's all we have right now. I'll allow a few more minutes for some questions in case anything else rolls in, but if anyone has a question, just feel free to type it in, or you can come on your mic and camera, or just the mic, or just to ask your question. Dr. Rowan, I'm not seeing any more questions, so I think that's all we'll ask for you tonight. And thank you so much again for taking some time off during your vacation to come and talk to us. I really appreciate it.
Absolutely, and thanks for having me, and I look forward to talking to you guys soon.